So for a study that started in 1994, there is considerable amount of background. So 30 to 40 years ago, preclinical and observational studies suggested dietary fat intake may be related to breast cancer outcome. Studies mainly centered on looking at stage-by-stage outcome comparing women in Japan to the UK and the United States. Preclinical data also supported that. There's plausible potential mediating mechanisms, so reduction in dietary fat intake reduces estrogen levels, linoleic acid, insulin-like growth factors, changes glucose metabolism, and changes inflammatory markers. So in a 6-institution, 300-patient feasibility study before this, we demonstrated the feasibility of achieving dietary fat intake reduction in a breast cancer setting, and a randomized clinical trial was begun in 1994. Here's the study design. Largely postmenopausal women. At that time, we weren't deciding pre and post. We were using age cutoffs, 48 to 79 years of age, stage 1 to 3A, breast cancer, primary surgery, radiation therapy, standard systemic therapy in use in 1994, and we'll see what that is. And the women had to have a dietary fat intake greater than 20% to enter. 2,437 women were entered from 39 U.S. clinical sites. This was run as an R01 outside of cooperative group settings, so there's no guarantee of ongoing funding support for follow-up. We did a 60-40 randomization. A few more in the control allowed us to direct more resources at the dietary intervention. You can see accrual was from 94 to 2001. Intervention ended, and funding ended in May of 2004, and so we really had no additional contact with the individuals after 2004. We were able to achieve a dietary fat intake reduction. Here's a kind of normal distribution. The women were taking in about 30% of calories from fat at entry. You can see the overlapping in the panel on the right. You see the problem of a little bit of problem for lifestyle interventions. You can see we moved the mean data from 30 to 20 in the intervention group, but you can see that about a third of the women then would be taking in the same amount of dietary fat. So it'd be like running a pertuzumab trial and giving 30% of the patients in the control group the pertuzumab. Even though dietary fat intake was not an intervention target, if you're adhering to a low-fat diet, it's pretty easy to lose weight. And we had this consistent 5 to 6 pound statistically significant weight loss that was achieved. I should say in the intervening kind of 20 years, it's become clear that probably weight loss is probably more important than dietary fat in terms of influencing breast cancer outcome. Here was the results that we had previously published. This relapse-free survival was reduced by 24% in the dietary group. This was a plenary presentation at ASCO in 2005. And you can see that there was more of an effect in the ER-negative, PR-negative subgroup, both for preliminary results for survival and also for the relapse-free survival events. Oh, I should say the funding and intervention ended in May 2004. Follow-up has been through 2013 with death registry follow-up only. So after 2004, we're only able to find in almost all circumstances only individuals who have died. The follow-up is 19.4 maximum amount of years. So here's the number entered that you saw before, the number of deaths in each group with the 60-40 randomization, and representing 17% of women died in the control group, 13.6% in the diet group. But when we put these into a Cox proportional analysis, show Kaplan-Meier survival curves, you can see the curves crossing at 10 years. The results were about 20% apart after 10 years follow-up, but there was some coming together of the curves, so the hazard ratio is 0.94, not statistically significant. Similar findings in the hormone receptor positive group. When we look at the hormone receptor negative group, where we see now a hazard ratio of 0.64, 36% improvement in overall survival. This is all-cause mortality, p-value of 0.045. Median survival is 1.9 years greater in the dietary intervention versus control group. I'll show this cumulative hazard ratio for death by randomization group. Remember, the intervention was on average 5 years. Some individuals got a little less than 5 years, some a little bit more, but not too much different. And you can see that at year 10, which would be 5 years after the intervention ended, the hazard ratio is 0.58, and then you see some kind of subsequent drift kind of upwards. We think this is the kind of most intriguing aspect of the data analysis. Here's the survival by ER in women who are ER and PR negative. You go down from 742 now to 362 women, and though HER2 status was not available at this time, SEER data just recently published, looking at all the data in the United States from 2002 to 2012, indicates that this group of patients would be 73% triple negative. So this is largely a triple negative result, suggesting a 54% improvement in survival with a hazard ratio of 0.46, p-value of 0.006, with a 2.3-year increase in median survival. Now, I should say now the obvious limitations of the study. For a study with 20-year follow-up, this is a post hoc analysis. The subgroup analyses were not pre-planned. These are all exploratory analyses. And of course, we do not, and the therapy, which I didn't show you the therapy, but the therapy was 53% received chemotherapy. All the patients with hormone receptor positive disease received tamoxifen. Here's the data again for that ER negative, PR negative subgroup, and you can see in the first 10 years, the hazard ratio is 0.31, so 69% fewer deaths at that point, and then a little bit drift away from that value. So here's our conclusions. Lifestyle intervention targeting fat intake reduction associated with weight loss, which we think is an important parameter, did not significantly increase overall survival of women with resected breast cancer receiving conventional cancer management. Exploratory analyses suggest favorable lifestyle influence on survival in hormone receptor negative subgroups and during active intervention. Something we didn't address, but I think this is important given emerging evidence over the last 20 years. Future lifestyle interventions should best target weight loss maintenance, increased physical activity. I should say, in terms of trying to put this into some context, I separate the context out. On a scientific standpoint, others will have to look at these exploratory post hoc analysis and decide whether they warrant support in a further randomized clinical trial to try to confirm some of these findings. So that's the scientific aspect. On an operational basis for a woman with breast cancer, there are health benefits associated with a 5% 5-pound weight loss. We've already seen in randomized clinical trial setting that amount of weight loss will prevent progression from pre-diabetes to diabetes. So I think this is something that a woman with breast cancer should consider almost as a separate issue. Thank you for your attention.
Thanks, Rowan. So when I look at these results, given the caveats that you mentioned, they're really pretty remarkable in the ER-negative subset, showing that results reducing your risk of death that are as good or greater than what we see with our best treatments. And I wonder, given the other positive features of weight loss and controlling your diet and so forth, whether you shouldn't be stronger in your conclusion. And the second question, and part of that, now that we know that it's probably not the fat, it's probably the calories, and we know that carbohydrates are worse than fat, at least that's the current thinking, maybe a low carbohydrate diet would be the one to recommend.
Yeah, I think that's right. I mean, when the therapy that individuals received was half received CMF, about 40% of the patient got chemotherapy, got adriamycin, only 6% got taxane. But having said that, contemporary chemotherapy doesn't do much better than those older therapies. So we've really been stuck with triple negative cancer. So I think with all the caveats, it is a very intriguing result. I should say that NCI has under review a current full-scale proposal based on a feasibility study to do a dietary to weight loss maintenance physical activity, essentially delivered intervention that they'll decide in January whether they'll go ahead with.
Well, it's interesting that all of us as oncologists we have fancy outfitted infusion centers for our treatment and so forth, and yet I bet you that very few of us really take dietary intervention as seriously as we do our other treatments.
Yeah, I think one thing is that many oncologists, maybe scientists, feel how can a weight loss strategy compared to, we see wonderful complexity over the last several days. And my answer is this is a multi-component intervention. We don't know what the components are. We're not guessing which TKI site to block. We have a multi-component intervention that over evolution has been shown to be better for us. So I think, though we don't know what the mechanism is, I think that's kind of the answer, that it may be quite complex.
Marisa Weiss, breastcancer.org. We actually did an interesting study of survivors that showed that 2/3 of them were willing to do weight loss to lower their risk, but only 14% were willing to reduce their alcohol consumption to lower their risk. But my question is, given that African American women are more likely to be overweight and also have hormone receptor negative disease, how much representation did they have in this study?
Yeah, it wasn't a large representation. I'll show the data this morning. I think it was around 9%. It was not, didn't reflect the U.S. population. It was not an enhanced population.
Zosha Chusteka, Medscape Oncology. Do you have an explanation for why there was a statistically significant effect in the ER negative women, but not in ER positive? I mean, doesn't that blow out of the water the idea that, you know, it's reducing fat, and fat has estrogen and all of that theory? And
Yeah,
I've got another question, if I may.
Sure.
I wanted to ask about, can you describe what the dietary intervention
Sure.
consisted of? Thank you.
Yeah, we'll take the first question. Yeah, so the data strongly suggests it may not be estrogen. One of the things I should mention is that the other way to look at that break is that the ER negative, PR negative group were no tamoxifen group. The ER positive group were a tamoxifen group. So it's a question about additional complexity would be a potential interaction between tamoxifen and the intervention in terms of weight loss, which we just thought of and we'll look at now to see if tamoxifen interfered with the weight loss. The fact that I don't know what the mechanism is shouldn't be an issue, because I think probably we've been working for 15 years to get a correct mechanism to target. So like I said, it's multi-component. There's a few things I could point out. Probably glucose metabolism, markers of inflammation might be the most reasonable places to look. Oh, about the second thing about the intervention. So the intervention was 8 one-on-one visits with the registered dietitian who had been centrally trained on this previously developed low-fat eating plan, which we showed were successful. Women were seen every 3 months by the registered dietitian, had a keeping score book that they kept daily, which they did for about a half a year, and then they kind of trailed off on the use. We assessed what they were eating with unannounced 24-hour recalls, but we feel that the weight really supports the fact that a dietary change occurred.
I just want to clarify.
Yeah, Charles Bankhead, MedPage Today. Have there been any trials in triple-negative breast cancer to date that have included a dietary intervention aimed at weight loss? And if so, were there any differences between the women who did and did not have the intervention?
No, but there are two ongoing studies in Europe. So Diana 5 is in Italy. It's targeting weight loss, weight maintenance, and increased physical activity with their weight loss based on a Mediterranean diet. They are looking at trying to oversubscribe for ER patients based on our previously published findings. Then there's a Success C study in Germany, which is doing, again, ER negative, ER positive, but about 1,000 patients randomized to a centrally mediated study looking at weight loss, weight maintenance, and increased physical activity. That's the way I think all the future lifestyle studies in this area will be moving forward.
But none specifically looking at triple negative?
No, like I said, the Italian study is oversubscribing for triple negatives.
Yes, I just want to clarify, your second bullet point reads kind of confusing to me, but your influence on survival in the hormone receptor negative group was seen at multiple time points, like throughout the study?
Yeah, so in the ER negative, PR negative group, the survival difference became statistically significant after 3 years of cumulative follow-up.
Okay.
And then it maintained the difference. The difference kind of peaked at around 10 years and then drifted off a little bit subsequently. Again,
Okay.
we're getting further and further away from the intervention.
I was asking because it says something about during active intervention.
Oh, yeah. The during active intervention means that in all the data displays that I've showed, the peak of effect was away from the 20-year follow-up. It would have been at either 7 or 10 years. So
7 or
so
10,
that
okay.
meant that it seemed like that as you further you got away from the intervention, the apparent effect weakened.
And one more thing, would you stratify your recommendations according to what type of cancer the woman has? Because it obviously was very strong in triple negative, strong in HR negative, not so strong in positive.
Yeah, I think it's very difficult to do that. I think, like I said, there's this interaction. We're looking at tamoxifen versus no tamoxifen in the group. We have some other analyses to do. I think it's really premature to say that this is only a estrogen. Since I can't say it's an overall effect, it's premature to say that you shouldn't do it in hormone receptor positive patients.
Thank you. Tessa Lange from the Dutch Oncology TV. So there's also even a better outcomes for the ER negative, PR negative patients. Can you explain what the cause of that may be? Because for the ER negative, it can be the mechanism with tamoxifen, which is absent then. But how about the ER negative, PR negative?
Yeah, so I think we've seen in this meeting some elegant discussion of potential differences of triple negative cancers, ER negative, PR negative, HER2 negative, that they represent maybe 3 or 4 individual subgroups which differ from the rest of the cancers. So I think I view this with 73% likely triple negative cancers. I view this as fitting into that very complex category that's different from many of the other breast cancers.